record because I keep forgetting, and for some reason, the auto record is not working. So, without any further ado, post-operative risk stratification, we have the standard risk tumors here. In fact, I will use the color that the book is using, which is yellow, right? Greenberg uses a yellow tone for the standard risk tumors. If you remember, there was a yellow tone sonic. So, what are the standard risk tumors? Total or near total surgical resection. Can anyone explain what is near total surgical resection for medulloblastomas? What's the minimum amount of tumor that you can leave? Anybody? No one? Somebody is writing in the chat box. Yes,
Less than
1.5
one.
centimeter square. Who was the one who was talking? Please say that again. No?
Yeah, it was me. Assalamu alaikum. Like I
Walaikum
was saying,
assalam,
it's
Dr.
less
Isra.
than 1.5.
Yes, this is less than 1.5 centimeters square. This is the amount of tumor you can leave as a residual, and it will still be considered as a near total resection instead of a total. So, this is one of the categories of the standard risk tumors. The other category is there are no mets, then there are no tumor cells in the 2 weeks post-op lumbar tap that we do, and there is no evidence of extra CNS metastasis. Essentially, what we are trying to say here is that there are no mets, there is total or near total surgical resection, and there was a specific subgroup which was standard risk in stratification. That was sonic hedgehog activated, TP53 wild type with classic histology. Do you all remember the sonic in the yellow jacket? And
Yes.
then we have the group 4 with classic histology and no METs, a diagnosis, and no favorable chromosomal findings. So, can someone volunteer and tell me what were the favorable chromosomal findings? Is my voice fine or is it breaking?
Yes, ma'am, it's fine.
It's fine. Okay, somebody has written in the chat box that it's
Ma'am,
breaking.
chromosome 7 gain and 17 gain is considered favorable,
Okay.
and 8 and 11 is considered, if it is lost, so that is also considered as a favorable.
Brilliant, Dr. Jas. I'm so happy that you have remembered that. Uh,
Thank
so
you, ma'am.
when we do not have favorable chromosomal findings, this is considered a standard risk tumor. And in the same group, if we have favorable chromosomal findings, then it gets downgraded as a low risk group, right? It goes green from the yellow. And then we have group 3. Group 3 was colored a big yellow box. You all remember, I hope. And then wingless tumor with classic histology, age more than 16 years, a lonely guy with broken wings sitting in a lake, pretty sad looking, but he was a standard risk tumor. So anybody who has attended previous sessions, they will remember the references I'm making right now, and all the new participants that I'm seeing. If you don't understand the references, that's completely okay. I'm going to upload both of those videos today, inshallah, after this session. So, this is the standard group, and let me move on to the next one. These are the low risk tumors, right? Let me change the color. The low risk tumors are color coded green. In the Greenberg WNT activated group, leave this. If you remember beta catenin mutations, perfectly fine. If you don't remember, that's also okay. But you should remember WNT activated group or sonic hedgehog TP53 wild type in infants. If you remember, infants were two green boxes at the lower two rows of that chart. And what were those? They were divided histologically. Desmoplastic nodular or extensive nodularity, and both of these in infants were considered low risk group, right? So either these or wingless tumor activated group or total or near total surgical resection. These are the low risk tumors. Let me move on to the next slide. So these are high risk and very high risk tumors. For high risk, we are going to use orange. We remember that large cell and anaplastic histology is an independent poor prognostic factor, right? Especially if it is present in group 3. Group 3 is not a nice group. If you add it with large cell anaplastic histology, it becomes a very wild group with a poor prognosis, and usually these are categorized as high risk tumors without metastasis. If there are mets, then it gets graded as very high risk, where we are going to go. Classic histology, sonic hedgehog, TP53 mutant. You all remember this suited sonic looking pretty tame, but not as tame in the behavior. So that was the classic histology, sonic hedgehog activated, TP53 mutant, and group 4 with METs at diagnosis. Because group 4 otherwise is a standard risk or low risk group, but if there are METs at diagnosis, it becomes a high risk tumor. These are three main molecular categories. Apart from this, if we see that the lesion is unresectable, there is non-compromisable adherence or infiltration of the fourth ventricular floor, or if we have to leave the residual tumor more than 1.5 centimeters square, either of these situations grade this risk stratification as high risk. And there are extra CNS metastasis. So somebody in a previous session also asked about extra CNS mets. And Dr. Fatma, I think, answered that in the chat box, that they can metastasize to the bone. They can also metastasize to the peritoneum via VP shunt, even though that's not as high of a probability as it is quoted. Apart from that, lymph nodes are also a possible site of metastasis. There are some case reports that suggest mets in the lungs as well, but that's very, very rare, probably one or two. So, very high risk tumors, they are color coded red, and these are large cell anaplastic histology, sonic hedgehog activated, but TP53 mutant, are group 3 with mets. This is a very quick revision of what we covered in a session before yesterday, so that we can go on for the NCCN guidelines today. This is Chang's staging. It's pretty straightforward, no complicated stuff here. M0 is no metastasis. M1 is only microscopic tumor cells in the CSF. When do we get this CSF? We get this 2 weeks post-op. And why 2 weeks only? We have also discussed this regarding ependymomas, but the reasoning remains same. M2 is gross nodular seedling in the cerebella, cerebral subarachnoid space. If you remember the first image that I showed day before yesterday, there was gross nodular seedling in the entire ventricle. Dr. Mustafa did a really good job of narrating the radiology, and that was M2. If you see gross nodular seedling in the spinal subarachnoid space, it's M3. And if there are mets outside the CNS, it's 4. So I remembered this during my exams with the help of a very easy thing. If it's M2, M2 means it's brain. If it's M3, M3 means it's a spine. And if it is M4, M4 means it's extra CNS. Outside CNS, wherever it is. So this is how I remembered it, because otherwise remembering all these long statements is, I don't think it's exactly possible. This is all very volatile. So we come to the most boring section of medulloblastomas. I think you have all figured out I do not like them as a pathology. They are very difficult to understand and they are even harder to teach, but we will do the best. So, what are the NCCN 2025 guidelines? They say they heavily favor telovelar approach. Why do they heavily favor telovelar approach? Can someone turn on their mic and let me know what are the pros and cons?
Natural. What's the natural corridor? It follows the
That's
natural
right.
corridor.
Natural corridor.
Okay.
Yeah.
So that was a very good input. I got a very good reassurance that you people are not sleeping. So yes, that's a natural corridor. And what are the cons? Can someone unmute themselves?
Not suitable, not
There
suitable
might be
for.
injury to great vessels, pica, like
Okay, but we see pica very clearly when we are doing the telovelar approach, don't we? Because we retract the tonsils on one side. But yeah, the injury can be
yes,
possible.
ma'am. Yeah.
Okay, so Dr. Nafia is writing that there is lesser risk of cerebellar mutism in telovelar approach, perfectly fine. That is why it is recommended heavily. And pica is with vermion. No. Pica is more at risk of damage during the telovelar approach because it's very clearly visible. That's both a pro and a con. Since you can see it, it's less likely to get injured because it's visible, obviously. But because it's also easily accessible within the surgical field, you can, if the patient is really unfortunate, you can nick it up. Whereas when we are talking about the transvermian approach, we injure the vermian vessels there. Pica is far, far away. We are hitting the midline there. What are the cons? Apart from the pica, what are some other cons?
We cannot reach to the superior regions. Superior.
Exactly, Dr. Mustafa. When we draw the fourth ventricle here like this, and let's assume that the lesion is somewhere here. When we do a telovelar approach, I'm going to draw it with a white line, assuming that this is the telovelar approach. Please excuse my drawing. So we are going to see a very high up and a narrow view. The corridor is very narrow. The view is really high. The superior axis is not as good in comparison with if we go transvermian, which is a midline corridor, right? So, one of the limitations of telovelar approach is that if the lesion is superiorly situated, it's difficult to access. The other glitch is that you are going to need a more advanced microdissection because there is going to be a lot of arachnoidal dissection involved. And if somebody is not very comfortable with the anatomy and they have not done a few of the approaches, it's going to be a very difficult approach in comparison with transvermian, which is more straightforward. So technically, transvermian is easier and better for the surgeon, whereas telovelar is it's not easier on the surgeon. There is a steep learning curve, but it's better for the patient in most of the cases. Apart from that, we are going to have a dedicated section in terms of discussing the just give me a minute, somebody is writing something in the chat box. We are going to have a dedicated section discussing the posterior fossa approaches. And yes, Dr. Ikra is writing that inferior vermian vein is compromised as well. That's right. So, nonetheless, even if we take in consideration all the pros and the cons, NCCN guidelines heavily favor telovelar approach. And this was one of the key focuses of the 2025 quality of life updates. So, moving on. Maximum safe resection is still the standard. We have already gone through it. Total or near total resection is our target. That is the goal. If you can take out the entire tumor, take it out. If you cannot take out the entire tumor, an acceptable residual is less than 1.5 centimeters square. Why this? Because more than that, it does not significantly improve patients' progression-free survival and overall survival. Let me move to the next slide. So, what do we do with infants? Can someone volunteer, please? Even though it's written, I know.
Less than 3 years, the radiotherapy is not suitable. Therefore, we go for chemotherapy.
Exactly. Why is it not suitable?
Because of myelosuppression.
And there's a better
and
reason.
cognitive dysfunction as well, ma'am.
Exactly, Dr. Jas. Yes.
Yes, ma'am.
So, The broad term is infants. Good term is less than 3 years. Why? Because under 3 years, the brain is growing at a rapid speed. And if you end up giving them radiation, there is a very significant amount of neurocognitive damage, and it's not worth the risk. Basically, even if you end up saving the patient, they are going to be mentally disabled for the rest of their life, which is not our goal. Our goal is preservation of life, but also preservation of function. There is no use of saving a life if it's not functional. So the goal for infants remains radiation sparing or radiation delaying. For wingless tumors, this is mostly radiation delaying. You would have to give them radiation later on, but for other groups, radiation is sparing is still acceptable. And we have to give them chemotherapy. I just wrote the names so that you have an idea what kind of chemotherapy we are giving them. Carboplatin, etoposide, cyclophosphamide, and sometimes we go through the autologous stem cell rescue. Let me change the slide. Give me a minute. So these are the standard risk group. And what are the standard risk groups? We have already established them, right? Let me turn on my marker. Older patients, more than 3 years, standard risk, which means total resection or near total resection and specific medulloblastoma groups. In them, we give them 23 grays, 23.4 grays, which is the established standard reduced dose for craniospinal irradiation, whereas the total dose to the tumor bed or the posterior fossa remains 54 grays to 55.8 grays. Also remember, these are NCCN guidelines. Some of them do overlap with the Greenberg. Sometimes they do not overlap with the Greenberg. If you're an exam candidate and you're appearing in a theory exam or a board exam, you should know what the most recent guidelines are. But quote the book first, CNS 21, because that is the most established guideline so far. If you are asked about the most recent updates, only then you are going to quote NCCN, and only then you are going to quote these doses. Because for standard risk, if I remember correctly, they overlap with the Greenberg, but for the high risk, they don't. Let me move on to the next slide. So for the high risk group, older patients who are more than 3 years, 36 grays is the conventional dose. For those with metastatic disease, M1 to M4. Can someone quickly revise what was M1?
M1
Yes.
is
No meds. Sorry.
M1 is no meds. Then what was M0?
M1 was when it was
M1
no.
micros meds, ma'am, and the CSF.
Oh,
TSF is for
Microscopic meds, ma'am.
Okay, I think I need to go back to that slide. You have not remembered it. Let me go back. So, take a very good look. M0 is no metastasis. I like to say it M0
Yes, ma'am.
because M0 does not refer anything. You say M0 and you automatically remember that there are no mets. When you're saying M1 means microscopic tumor cells in the CSF. There are mets, but they are not visible, right? So M1 is no visible mets. There are mets, but they are not visible. They are microscopic. M1 is I, and that is how you can remember it. If you assume that this 1 is also an I, these are microscopic tumor cells. What is M2? M2 was brain, right? M2 was
Yes, ma'am.
brain, M3 was spine, M4 was anything outside brain and spine. M0 none, M1 is micro, M2 is brain, M3 is spine, M4 is anything outside the brain and the spine. Let's go back to the slide we were on. So yes, we are here. Metastatic disease M1 to M4, which means any form of metastasis, even if microscopic, it gets termed as a high risk. And this is self-explanatory. Significant residual tumor. What we do in these patients, we give them a boost to the metastatic sites and the primary tumor bed. And the target dose is still 54 to 55.8 grays. There's another group. So I already mentioned this, that for wingless tumor subgroup, the WNT subgroup, there's a strong recommendation. I know we do not have a lot of trials in Pakistan going on, maybe in Shaukat Khanam or maybe in AKU. I don't know about other setups. I have only worked in public sector tertiary care hospitals. So we did not have any clinical trials in there. For wingless tumor subgroup, we have to send them in clinical trials outside Pakistan or wherever it is accessible for the patient. And we can try lower doses of craniospinal radiation. There are different articles for this. One proposes 18 grays. There are others which say 15 to 18 is an okay range for this, but do not quote this in exam. These are all newer guidelines, and their cure rates are very high with the radiation. When do we give proton therapy? Do you remember the brain and spine imaging session? What is the difference between the proton therapy and the conventional therapy?
Proton therapy, less exit dose, so less radiation exposure.
Exactly.
This is number
Yes,
one.
there is less radiation exposure. Along with that, it's also safer, which is the same thing. The conventional radiotherapy is the photon radiotherapy. For children, ideally, we have to go for proton radiotherapy, but I think it's not as easily available in a lot of setups, and it reduces the long-term damage. There's less radiation necrosis associated with it, but it's not as easily available. Moving on. Surveillance is really, really important. For first 3 years, you are going to ask the patient for an MRI every 3 months. And there is this new emphasis in the recent guidelines on neuropsychological testing. Why? Because we want to monitor the cognitive effects of radiotherapy. And that is obviously only possible if one is working in well-resourced setups. But it's something that you should know. And that's a wrap for medulloblastomas. I'm so happy we got done with them. I'll go and I'll upload all of the recordings today, inshallah, after I am done with this one. And you can ask any questions, you can give any feedback. Tomorrow we are going to have the neurovascular imaging, CT angio and DSA, MR angio, etc. Do not miss it, please. And on Thursday, we are either going to have posterior fossa meds or pilovestro.
Thank you, Dr. Kanwal. Assalamu alaikum.
Walaikum assalam, Dr. Ikra. Any questions, any
How are you?
feedback?
Yes. I wanted to ask a question regarding medulloblastomas.
Okay.
Do you know which is the most common group of medullo? Group 3, group 4, or non-activated or mutant?
I don't exactly remember. Group 3 is, I think group 4 is more common.
It's group 4, ma'am. It's
Yeah, it's group 4
35%.
is more common. Yeah, Dr. Fatma is
Okay.
saying that's age specific. That's also a very good answer. But overall, I think group 4 has a higher incidence in comparison. Group 3 is the more, group 3 is the one that is more
Notorious.
dangerous. Yeah,
Yeah.
it's more hazardous, along with SHH TP53 mutants.
Okay. Thank you.
Any other questions? Any feedback? Okay, everyone. So that's a wrap for today, inshallah. Have a good day, good night, good evening, whatever time zone you're in. Thank you so much for attending. And let's see you all tomorrow, inshallah, with Dr. Itazaz, hopefully. Thank you, Dr. Dalita. I noticed the heart. Thank
Thank
you.
you, ma'am.
Thank you. Thank you so much.